We are now going to turn our attention to gross anatomy and begin the process of working our way through the body. And we're going to start with the back. So what we want to do in this section is to focus on the vertebral column first and the spinal nerves and know the anatomy of those structures. We want to understand the difference between somatic and autonomic nervous systems. And then within the autonomic nervous system, we want to differentiate between the sympathetic and the parasympathetic nervous systems. So we will first look at the vertebral column, and then focus on the intervertebral disc, and then look at the spinal nerve, and then spend a fair amount of time talking about the autonomic nervous system and its two components, the sympathetic and the parasympathetic nervous systems. So let's start with this slide showing the vertebral column. And on these three diagrams, the one on the left, we're looking at the vertebral column from an anterior view. We're looking at it from the front. And what we can see from this view is primarily the vertebral bodies and the intervertebral discs, the intervertebral discs between the bodies. Now, the function of that part of the vertebral column is to support weight. That's what it's designed to do, to support weight. And therefore, it makes sense that as we view the vertebral bodies from above downward, we see that the sizes of the vertebral bodies get larger and larger and larger as we descend the column. And of course, the discs are getting larger as well, because as we descend the vertebral column, we're supporting more and more and more weight. So as we support more weight, we want a larger vertebral body upon which to support that weight. So that makes sense. But take note that as we continue to descend and we pass the first sacral vertebra, all of a sudden we see that the vertebral bodies start getting smaller very rapidly. It reverses its pattern, and after getting gradually larger, suddenly it gets smaller. So the obvious question is, why should that be? What happened to the weight? Well, we notice that transition occurs right at about the level of S1, and that corresponds to the location of the sacroiliac joints, here and here. And at the sacroiliac joints, the vertebral column is articulating with the pelvis. And so actually what's happening is the weight that has been transmitted down the column gets transferred across the sacroiliac joint to the pelvis, and then from the pelvis down the lower limb. So once we get below that level, the vertebral column is no longer supporting weight. The lower limb is supporting the weight. And therefore, we see that very dramatic change in anatomy, reflecting the change in function. What that is basically telling us is that in the vertebral column, the greatest weight-supporting function of the column is found at the low lumbar and lumbosacral junction region. That's where the greatest weight support function of the column is, in this region. And therefore, it's not a surprise to learn that most of the weight-related injuries of the vertebral column, things like compression fractures of vertebral bodies with osteoporosis, things like herniations of intervertebral discs, the most common site for that to occur would be in the low lumbar and the lumbosacral junction region. That's not a big surprise. Okay? Now, when we look at the lateral or posterior views of the vertebral column, we can see the back of the vertebral column, what's called the vertebral arch or the neural arch of the vertebral column. And the function of that part of the column is quite different. That part of the column is designed to protect the spinal cord and surrounding meninges. So within the vertebral column, surrounded by the vertebral arch, within the vertebral column, there's a canal called the vertebral canal, and what is sitting within the vertebral canal is the spinal cord with its surrounding meninges. So here's the point. Since the spinal cord is inside the vertebral column, and since the spinal cord has spinal nerves that are emerging from the vertebral column and have to get to places outside the vertebral column to innervate them, there has to be a way for these spinal nerves to get from inside the column to outside the column. And what we have to allow that to happen is the intervertebral foramina, here, 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 here. Those are each intervertebral foramina. And what passes through each intervertebral foramen is a spinal nerve. There is one spinal nerve in each intervertebral foramen. Okay? And that's going to be an important region for the spinal nerve because as it's passing through that foramen, it's in a relatively tight region. There's not a whole lot of extra space there. And so when nerves pass through tight regions, they're subject to injury in those locations. So the intervertebral foramen will be a location where nerve injuries can occur, and we will talk about that. Another opening I want to point out to you can be seen on the posterior side of the column, and it's seen only at lumbar levels here. And these are openings between the laminae of the vertebrae. This flat surface of the vertebra is called the laminae of the vertebrae. And the spaces between the laminae are called interlaminar spaces. Interlaminar spaces. Now, interlaminar spaces only exist at lumbar levels. Below that, at sacral levels, the laminae are fused, so there are no spaces. And above that, the laminae overlap one another, so there are no spaces. But at lumbar levels, there are spaces called interlaminar spaces. And the reason we're interested in them is that those spaces are used clinically because that is the access point that we have for doing lumbar puncture. Lumbar puncture. So the reason we have lumbar puncture, you don't have sacral puncture or thoracic puncture, you only have lumbar puncture, is because that's where you have interlaminar spaces. Okay? And we'll talk about lumbar puncture in just a few moments. Now, when a lumbar puncture is done, the most common site for doing the lumbar puncture is at either the L4, L5 interlaminar space or the L3, L4 interlaminar space, one of those two. And we'll see why that's true in just a few minutes. But for right now, what that means is if we want to find the L3-4 or the L4-5 interlaminar space, what we're really saying is we need to be able to find the L4 vertebra, to find the space just above or just below that vertebra. And so we'd like to have a landmark that tells us where L4 is. And that landmark for L4 that we have is the top of the iliac crest, the top of the iliac crest. So if you draw a line from one iliac crest to the other across the back, where that line crosses the posterior midline, that line will be right on the spine of the L4 vertebra. And then if you put your finger on that spine and then just slide your finger up or down, you'll be sliding your finger to the L3-4 or the L4-5 interlaminar space. So let's talk about lumbar puncture for a moment. So as we've said, this is a clinical correlate in your notes, that in order to perform a lumbar puncture, you pass a needle through an interlaminar space. It's done in the midline, and it's done while the vertebral column is flexed. Well, why is it done when the vertebral column is flexed? Because since the interlaminar space is your target, that's what you're aiming for with your needle, you'd like that target to be as large as possible. And by flexing the vertebral column, you're spreading apart the laminae and thereby increasing the size of the interlaminar space. So flexing the vertebral column gives you a larger interlaminar space to aim for. So it's done with the patient's vertebral column flexed. And it's done at the L4, 4-5 or the L3-4 interspace. Now, as you pass your needle through at that level, you're going to go through several layers. And the layers are listed for you in the notes from outside in, skin, superficial fascia, and so forth, all the way into the subarachnoid space. And of course, the subarachnoid space is where the cerebrospinal fluid is. So it's important that you know what the layers are that your needle is passing through as you advance the needle, because as you go from layer to layer, you can feel the changes of resistance, and thereby you can sort of, if you know what the layers are, you can count off the layers so you know where the tip of your needle is as you're advancing your needle. Now, if you're putting the needle in for the purpose of doing a tap, a spinal tap, you want to get to the cerebrospinal fluid, then of course you need to advance the needle all the way to the subarachnoid space. But of course you could be putting a needle in for the purposes of doing epidural anesthesia, let's say, in which case you would only advance the needle this far to the epidural space, and you would not go through the dura arachnoid to get to the subarachnoid space. So you want to know how far you want to advance the needle and what layers you're going through to accomplish that. Now, one additional opening I'd like to point out to you is seen right here at the very bottom of the posterior side of the vertebral column. It's called the sacral hiatus. The sacral hiatus is the inferior opening of that vertebral canal. We said the vertebral canal is where the spinal cord is housed. And it's open at the bottom. It's called the sacral hiatus. And that's important because you can pass a needle up into the sacral hiatus. And that's what's done when you're doing caudal anesthesia. That's the caudal approach. Caudal means from the tail end. So caudal means going through the sacral hiatus. And that'll bring the tip of your needle into the epidural space, as we'll see. So caudal anesthesia will always be epidural anesthesia. So let's look at this diagram that shows you the points that I've been making here diagrammatically. So it's showing you two examples of a lumbar puncture, and it's showing you at the two levels that it's done, either L3-4 or L4-5, these two examples. But the main point of these two examples is to show you that in one case, we're only advancing the needle as far as the epidural space, and in the other, we're advancing the needle through the epidural space, through the dura and arachnoid, into the subarachnoid space. And it's in the subarachnoid space where cerebrospinal fluid is found. Okay, so you would advance the needle into the subarachnoid space if you wanted to withdraw CSF, if you wanted to measure CSF pressure, or if you wanted to put something into the CSF, a drug, contrast dye, something like that, anesthetic. On the other hand, if what you wanted to do was put an anesthetic into the epidural space, then you would only advance the needle this far and not go into the subarachnoid space. As you can see, the epidural space that we see here is continuous all the way down to here. So here's that sacral hiatus that we talked about. So if you slide a needle up into the sacral hiatus, and you do a caudal anesthesia, you see that you're entering that same epidural space that you could also enter through lumbar puncture. Okay. Now, we can use this diagram to illustrate why we want to do a lumbar puncture at about the L4 level. So let us assume that we're doing the lumbar puncture for the purpose of getting into the subarachnoid space in order to withdraw CSF, to do a spinal tap. So that means we want to get into the subarachnoid space where there is CSF, but not where there is spinal cord, because we don't want to inadvertently injure the spinal cord. So in other words, we want to be in the subarachnoid space, but below the spinal cord. So what this diagram is showing you is that the spinal cord, the bottom of the spinal cord, in the average adult, is at about the L1, L2 level. On this diagram, it's showing you at L2. It could be anywhere in this region. Because remember, this is just an average. So we don't know where the bottom of a spinal cord is on an individual patient, but we know that on average, it's somewhere in the L1, L2 region. On average, about right in between L1 and a half. So we want to be below that. But again, the other thing we also want to know is how far down does the subarachnoid space go? Right? How far down does the subarachnoid space go? Because it's only if you're in the subarachnoid space that you can get CSF. And this is showing you that, again, on average, the subarachnoid space goes down to about the level of S2. Again, we don't know for any individual patient where it is, but on average, it's at about S2. It might be a little lower, it might be a little higher. So here's the point. In order to assure that we do not injure the spinal cord, we have to make sure that we're below it. Since we don't know exactly where it ends on any individual patient, you want to stay as far below as possible to make sure you miss the spinal cord. Okay? So if you want to stay as far below as possible, then why don't we go all the way down to L5S1? Right? That would be even better. But that brings in the other half of the equation, which is how far down does the subarachnoid space go? And again, we don't know for any individual patient. It's somewhere around S2. It might be a little higher, it might be a little lower. So to be sure that we stay in the subarachnoid space, we want to stay as far above S2 as we can. So if we want to stay as far below L2 as we can and as far above S2 as we can, the way we do that is find the midpoint, which is L4. So if you come in at about L4, which means either just above or just below L4, you've achieved the best of both objectives, staying below the spinal cord but staying above the bottom of the subarachnoid space. Keep in mind, however, that those facts about the bottom of the spinal cord and bottom of the subarachnoid space are applicable to adults. In young children, everything is a little lower. So in a newborn, the spinal cord on average comes down to about L3. So when doing a lumbar puncture on a child, you want to even be more concerned about staying low. So you certainly would not go to the L3-4 space. You would more likely go to the L4-5 space. Okay? Okay, so now let's turn our attention to the intervertebral foramen. So here's a diagram of several diagrammatic lumbar vertebrae. And we see an intervertebral foramen there. There's an intervertebral foramen here. There's an intervertebral foramen there. We said that each intervertebral foramen will contain one spinal nerve. So the spinal nerve is drawn in this case. Of course, there would be another one here. There'd be another one here. There's one in each foramen. And we said that as the spinal nerve comes through the intervertebral foramen, that's where it might get injured. That's where we can get into trouble. And so what could injure it? Well, whatever is forming the boundaries of that space could be the source of the injury. So we want to focus our attention on what's forming the boundary of the intervertebral foramen. And let's keep our attention focused on two boundaries, the anterior wall, or anterior boundary, and the posterior wall. So starting with the anterior wall. We see that the anterior boundary, or wall of the intervertebral foramen, is made up by the body of the vertebra above, just a little bit of the body of the vertebra below, and a fair amount of that anterior boundary is made up of the intervertebral disc. So that's an important relationship, that the intervertebral disc forms part of the anterior boundary of the intervertebral foramen. And the reason that's important is because sometimes intervertebral discs will herniate. So let's talk about that. And let's get a little bit more precise in our nomenclature. When we look at the intervertebral disc, on the left side of the diagram, we see that there are two parts of the disc. There's the outer part called the annulus fibrosus. Annulus means ring, fibrous ring. So it's made up of rings, concentric rings of fibrocartilage and fibrous connective tissue. And more centrally positioned, there is the nucleus pulposus, which is sort of a semi-gelatinous material with just a few cells in it. And remember, the nucleus pulposus is the adult derivative of the notochord. Of course, the annulus fibrosus is not from that. The annulus fibrosus, like any other connective tissue we encounter, is going to be from mesoderm. So those are the two parts, nucleus pulposus and annulus fibrosus. And when we talk about a herniation of a disc, that's not really a precise nomenclature. What's herniating is the nucleus pulposus. It's a herniated nucleus pulposus. It herniates out through the annulus. In other words, it passes out through a tear or a rupture of the annulus fibrosus. Now, notice that the nucleus pulposus is not really centrally positioned in the disc. It's actually somewhat posteriorly displaced. It's closer to the back wall. This is the posterior side of the disc. That's the anterior side. It's closer to the back wall of the disc than to the front wall. So it's not in the center, which means that the annulus fibrosus is thinner posteriorly than it is anteriorly. Which means that if the nucleus pulposus is going to herniate through the annulus fibrosus, it's much more likely to herniate through the posterior part of the annulus than the anterior, because it's thinner here. So that's true. We would expect that the nucleus pulposus herniation would be a posteriorward herniation, and that's just about always the case. Almost always. But notice that in the posterior midline, there is a reinforcing ligament. there's a ligament right here called the posterior longitudinal ligament. So we'll understand that better if we look at it here. There's the posterior longitudinal ligament. It runs up and down the length of the vertebral column on the posterior side of the body. It's going from one vertebral body to the next. And as it crosses from one body to the next, it's crossing right over the posterior midline of the disc. So as doing that, that's where we see it here. As it crosses over the posterior midline of the disc, it serves as a reinforcement to the disc. So while we said that the nucleus pulposus is apt to herniate in a posteriorward direction, it's not likely to herniate straight posteriorly because of the presence of that ligament. We would expect that it would herniate posterolaterally. And almost all disc herniations are posterolateral herniations, either posterolateral to the left or posterolateral to the right, or both. Okay? So almost all disc herniations are posterolateral, probably approximately 95% of disc herniations. The reason that's important is to recognize that if you go posterolateral to the disc, where does that bring you? Where are you when you're posterolateral to the disc? Well, that brings you right here. That brings you into the intervertebral foramen. So this nucleus pulposus is herniating into the intervertebral foramen. And we've said already that there's something living in the intervertebral foramen, the spinal nerve. And so if that herniated nucleus pulposus occupies enough space so that it starts to crowd the spinal nerve, it's going to cause the spinal nerve to get pushed up against and compressed against the surrounding bony wall of the foramen. And it's that compression of the spinal nerve that causes the symptoms. If it's a small herniation, it doesn't occupy very much space, and doesn't compress the spinal nerve, then it's not symptomatic. But if it does compress the spinal nerve, it's that spinal nerve compression that becomes symptomatic. So compression of the sensory fibers will cause sensory findings. In other words, sensory findings associated with the region of skin innervated by that spinal nerve. In other words, the dermatome associated with that spinal nerve. So it could be anesthesia, it could be hyposthesia, it could be pain, some kind of sensory abnormality. And compression of the motor fibers in that spinal nerve will cause muscle weakness in the muscles innervated by that spinal nerve. In other words, the myotome associated with that spinal nerve. Okay? So you'll have sensory and/or motor symptoms associated with the compression of the spinal nerve. But again, to reiterate, if there's no compression, then there are no symptoms. Okay? So that's the anterior boundary of the foramen. The posterior boundary of the foramen is formed by the articular processes of the adjacent vertebrae, and the joint between them that they form. That joint is called the zygapophyseal joint. It's a synovial joint, built just like any other synovial joint, and it's subject to diseases of synovial joints, in particular osteoarthritis, the degenerative, not the inflammatory arthritis, but the degenerative arthritis, osteoarthritis. Now, when you look at an osteoarthritic joint surface, articular surface, what you would find is that instead of having a nice, smooth articular surface, you'll find an irregular articular surface. In other words, you have abnormal bone resorption and abnormal bone deposition in the formation of what are called osteophytes, or bone spurs. Well, recognize that if you form an osteophyte in the region of the zygapophyseal joint, if that osteophyte projects anteriorly from the joint, look where it's going. It's projecting into the intervertebral foramen, and therefore it's occupying space in that foramen, and so we have the same story again. If it occupies enough space, so that it's causing crowding of that nerve, it causes compression of the nerve against the bony wall of the foramen, and that will be symptomatic. Exactly the same symptoms as we talked about with the herniated nucleus pulposus, because again, remember, it's the compression of the nerve that causes the symptoms, not whatever the pathology is that's causing the compression of the nerve. Okay, now let's focus on a sort of a variation on this theme that explains a particular clinical rule that's important you be familiar with. And the rule is this. When a single, when a herniated nucleus pulposus occurs, and if that herniated nucleus pulposus compresses one spinal nerve, sometimes it's such a large herniation that it can compress more than one spinal nerve, but if it's compressing one spinal nerve, the nerve that it will compress will be the nerve with the same number as the vertebra below the disc. The same number as the nerve with the number of the vertebra below the disc. So using this example on this diagram, we're looking at a herniation of the L4, L5 disc. And so we said that if it's going to compress one spinal nerve, it will compress the nerve with the number of the vertebra below the disc. So the vertebra below the disc is L5, so it would compress the L5 nerve, which is this spinal nerve here. So going back to our previous diagram for a second, if this represented L4 and if this represented L5, we said that that disc herniated, the nerve that would get compressed would not be this nerve, which is the L4 nerve, but rather the nerve that exits through here, which is the L5 nerve. So how do we explain that? Well, we understand, looking at this now, that the L4 nerve, it exits through this foramen, but it's exiting through the top of the foramen. The foramen is kind of large compared to the size of the nerve. So the nerve exits through the top of the foramen. The disc is forming the wall at the bottom of the foramen. So when this herniates, it misses that nerve. But what it gets is the nerve that's getting ready to emerge to the next foramen. In other words, the nerve that's descending through the vertebral canal, moving laterally to come out through that foramen, will get impinged over here before it ever gets to that foramen. And that's what we see on this diagram. There's the nerve that's exiting through that foramen. It misses that nerve, but there's the nerve that's heading down to exit through the next foramen, and it impinges that nerve. So it's injuring the nerve with the number of the vertebra below the disc.